Good evening, everyone. Welcome to Gut Over It. Thank you guys again for joining me again tonight. We are discussing a GI topic every single night, and as usual, we are discussing a very important GI topic, one that is critical and crucial that you always discuss with your provider or gastrointestinal doctor, your GI doctor, every time you think you have symptoms that could be suggestive of this particular organ. I can't believe we didn't talk about the pancreas. I mean, we're at 27 days. We didn't talk about the pancreas. And this is a very, very important organ in the GI tract. You guys, my name is Dr. Vivina Samwa. I'm a gastroenterologist and functional medicine provider in Katy, Texas. I am a board certified gastroenterologist trained at Johns Hopkins Institute of Functional Medicine provider as well with the IFM. And over the month of February, I have been talking about a very interesting GI topic, one that I feel is relevant enough for you to discuss with your primary care doctor, your gastroenterologist, and make sure you ask pertinent questions. This whole series, Gut Over It, has been about edutainment, providing you with the education so you are well informed as your own advocate. The best advocate is the own patient, your own person, right? To discuss with your provider so they can go deeper to root cause and figure out what to do and how to help you. That's our goal as providers, is to help. So thank you guys all for joining me tonight. It's so nice to see so many of you joining me on a Saturday night. If you are listening to this live, welcome. If it is your first time, enjoy. Please listen to all the other posts we've done. We've done 26 great topics over the past month of February. If you are listening to this on the replay, enjoy it. Please, guys, as usual, put in a like, share some love, leave a comment, put some questions in, and I will answer everything as we go along. This is the but one, and we have a wonderful Gut Over It tonight. I was going to talk about that hidden gem, the pancreas. And a lot of people don't like talking about the pancreas because we always think about pancreatic cancer. Because we remember people we know, people we have admired, people who are inspirational to us, who passed away tragically, almost heroes, right? Heroes who passed away from pancreatic cancer. It's a difficult cancer to diagnose. It's a difficult cancer to treat, and the mortality is extremely high. So again, tonight, we always want to honor and give recognition to those people who've passed away, who we admire, continue to admire, who continue to inspire us. And some of them are artists, some of them are businessmen, but all have made an impact in the world of gastroenterology in actually spreading this information about cancer, pancreatic cancer, and its awareness. We remember Patrick Swayze, we remember Steve Jobs. Aretha Franklin actually had a neuroendocrine tumor. I didn't know about it. So a lot of people have had pancreatic tumors. And I think that's why it's hard for us to talk about it as providers and also as patients in clinic. But tonight, we just want to talk about the organ. I don't want to bring a lot of fear. We don't want to have this fear about an organ. Being well informed about it also helps you get a level of comfort when you have symptoms to confront and have the testing that you need to have done so that you can figure out what's going on. So we're going to talk about the pancreas as an organ. And guys, please ask questions. This is an influencer. The pancreas is a tiny organ. It is a gland that sits cradled between the stomach, the gallbladder, the liver, the spleen, and the small intestines. And it sits way at the back. So whenever you have stomach pain, or you have pain right here in what we call the epigastric area, it could be the stomach, but what sits right behind the stomach is the pancreas. So if we do an endoscopy and we don't figure out what's going on, the job is not over. Your doctor's job is not over. We got to dig deeper because we don't see the pancreas on endoscopy. It is what we call a retroperitoneal organ, and it is relatively hard to see. So you got to do tests like CT scans, and sometimes that's not enough. You got to do an MRI. But let's talk about the function of the pancreas, why it's cradled between those different organs. And if you guys go back to the initial event poster that I did, you see the full anatomy of the pancreas. It's a tiny organ. It's about 6 inches long. It's cradled really deep in there, but it has an amazing function. Two really strong functions. It's got a group of cells that makes hormones, so insulin and glucagon, and it's got a group of cells that all they do is just make digestive enzymes and juices. And in the middle of the pancreas, you've got a large pancreatic duct, and then you've got tiny ducts that actually secrete all the digestive juices into the large duct, connect along with the biliary duct, right? And then dump everything into the small intestine so that food can get digested. And that is the work of the pancreas. That's its job. So it's got an endocrine function to make hormones, and it's got an exocrine function to make digestive juices. So it is an extremely critical, it's almost like the engine of the GI tract in some ways, right? It's the fuel, because without the pancreas, we can't digest. So without the pancreas, we can't eat. And that's a problem. That goes along with some of the symptoms we have. So when we talk about the pancreas, you can have three problems with it. We kind of talked about pancreatic cancer. We'll go into that in a little bit more detail. But let's talk about the most common things that can happen with pancreatic dysfunction. I'm trying to get rid of this light, guys. I just don't want it. There we go. All right. So you can have issues like pancreatitis, which is inflammation in the pancreas itself. I want to make sure everyone can hear me okay. Perfect. Yes, yes, yes. Because sometimes my volume's a little low. People can't hear me. Fantastic. Pancreatitis. Now, I have heard men say this is worse than childbirth. I don't know if it's true. I've never had pancreatitis, but I've heard women say the same thing. The pain from an acute pancreatitis is extremely intense. You feel it right in the gut. It radiates to the back. It is sharp and intense. It can come with nausea, with vomiting, just no urge to eat, no sensation of wanting to eat, no appetite. And the reason it's so intense, it's because what happens is there's inflammation in the pancreas, because the digestive juices that the pancreas actually makes digest its own cells. It's like cannibalism of the pancreas. The digestive juices made by the pancreas in the setting of inflammation digest the actual pancreatic cells. So it's almost like you put acid on something and it's just burning itself. And that's why the pain is so intense, incredibly intense. And pancreatitis can come, acute pancreatitis, which is the acute onset, right? You know, you're fine, you're walking around, and you had some drinks last night at the bar. You had maybe 4, maybe 5, maybe 6. Boom, the next day, severe epigastric pain, you're vomiting. I mean, you feel so uncomfortable, you're rushed to the emergency room. They do some lab work on you and they say your pancreas is off. And everyone's initial reaction is this pancreatic cancer. No, but your pancreas is inflamed. We can detect this on blood work, right? So we'll test for something called lipase and amylase that actually measure the levels of how much pancreatic enzymes are being released. And this can be, the normal level is supposed to be like less than 60. But in pancreatitis, the diagnosis is when it's 3 times the upper limit of the norm. And I've seen levels as high as 1,000. So imagine pancreatic juices being released, digesting the actual pancreas, painful. Alcohol is a very common cause. Second common cause, gallstones. So gallstones that get trapped in that duct. And that's why we say when you have gallbladder disease, you know, you could have a little bit of right-sided pain, but when you start getting complications like stones getting stuck in the duct and causing pancreatitis, that can be life-threatening, because acute pancreatitis is a very severe and significant disease, right? It's very, very, I mean, people die, people are in the ICU. So once you have it, you have to be very careful. So alcohol can cause acute pancreatitis. Gallstones can cause acute pancreatitis. Medications your doctors may put you on. So new medications that you're not aware of can cause acute pancreatitis. Guys, if you have questions, let me know. I'm sure a lot of you have heard of this diagnosis before. High triglycerides. Triglycerides are a type of fat. So it's like a lipid, like cholesterol. Then you have triglycerides, very high triglycerides. And there's some people walking around with hereditary causes of hypertriglyceridemia. Fancy term for saying your mom and dad gave you some bad genes. It resulted in high cholesterol, high triglycerides. And I'm talking the normal triglyceride is less than 150. But we sometimes see in hereditary triglyceridemia levels as high as 800 to 1,000. That itself is a cause for pancreatitis, right? So you've got a couple causes like that: medications, alcohol, gallstones, most common causes of pancreatitis. You've got autoimmune causes as well. So my people out there with autoimmune disease, you've got one, you get another, right? And how do we manage acute pancreatitis? We kind of talked about how we treated it, how we diagnosed it with doing the pancreatic enzymes. You need a CAT scan, because on CAT scan, we want to make sure and see if the pancreas is inflamed. But generally, we say you need about two of the three specific criteria to have the diagnosis. So you got the pain, check. Elevated pancreatic enzymes, check. CT scan or MRI showing an inflammation around the pancreas, check. You got acute pancreatitis. And with this diagnosis, depending on how severe it is, we want to keep you in the hospital because it's going to be bowel rest, because we don't want to stimulate the pancreas. We don't want to put food in the stomach that stimulates the pancreas to make more enzymes to cannibalize your pancreas, right? So bowel rest, no food, IV fluids, pain control. That's the way to go. And then, of course, fixing the root cause. So if you drink a lot, you got to stop. If you've got triglyceride issues, we got to fix it. If it's gallstones, we got to get in there, take the gallbladder out, or take the stones out of the duct. So that's acute pancreatitis, guys. And it's relatively common, but can be life-threatening. So we don't play with those patients, right? And so whenever you have, this is a tip for you guys, right? Whenever you have, I have a good question. Epigastric pain, endoscopy done, nothing. Ultrasound done, nothing. Your doctor says, I can't find anything, go home. Say, doc, no. Have you checked my pancreatic enzymes? Absolutely, you're right to ask, have you checked my lipase and amylase? Can you tell me what's going on there? Because sometimes they don't. So be your own advocate. Ask your doctors. Make sure we don't forget that hidden gem. That organ is extremely important. We'll talk about chronic pancreatitis now. So who gets chronic pancreatitis? It's people who tend to get recurrent episodes of acute pancreatitis. So they keep getting the hit. So the alcohol, maybe someone who drinks who can't stop, right? So they just keep getting hit. Triglyceride issues, couldn't get it fixed. And that person who says, I don't want my gallbladder out, and they just keep it in there and it keeps having complications. Sometimes chronic pancreatitis we'll see more often in people who smoke. There is also a hereditary and genetic cause of chronic pancreatitis. So there are different tests we can do to figure out whether you have the genes to keep having chronic pancreatitis. The problem with chronic pancreatitis is, unlike acute pancreatitis that just happens, you go to the hospital, you get bowel rest, you get some pain control, you go home, hopefully you're fine. Chronic pancreatitis is a smoldering pancreatitis. It's every day. So chronic is anything that lasts for 4 weeks. And, patients who suffer from chronic pancreatitis have a miserable life. They can't eat. They're chronically in pain. They're not digesting their food, so they lose weight all the time. And they have that funny stool. I think we spoke about it in one of our Gut Over. It's called steatorrhea. That's the oily emulsion because they can't break down fats. So when they eat fatty foods, all that comes out is oil. And that's they can't flush it. It just floats on the surface. So they're malabsorbing completely. They have no vitamins. They're very, very weak. And the pain is really intense. And we know that chronic pancreatitis, people who smoke are at very high risk of chronic pancreatitis. And chronic pancreatitis is probably the leading cause of pancreatic cancer. So one leads to the other. And whoa, guys, this brings me back to that functional medicine part. Chronic inflammation drives cancer, right? That's the connection right there. Imagine chronic pancreatitis, chronic inflammation over years, cancer. That is really the driving force that we're seeing, that connection in functional medicine, that clear connection between chronic stress to an organ, to a person, chronic inflammation, and then developing things like cancer. So chronic pancreatitis, again, the diagnosis, if you do blood work, you may not find the pancreatic enzymes are high. Why? Because your pancreas has eaten itself up and there are no more digestive enzymes to release. So your blood work may actually be normal. So if you see a provider who says, well, you can't have chronic pancreatitis because your pancreatic enzymes are normal, say, well, hang on, sir. I think that's false. I didn't go to med school, but I can tell you this. I have no more pancreas to give. But the way to diagnose chronic pancreatitis is CT scan, MRI, or a special endoscopic test. We did this on another Gut Over It, where we were digging deeper into diagnostic tests called endoscopic ultrasound. So now the endoscopic ultrasound is a very, very awesome diagnostic tool in gastroenterology. It's an endoscopy, but the end of the tip has an ultrasound probe to it. And we spoke about where does the pancreas sits? Right behind the stomach. So if you get in the stomach and you have your ultrasound, you can actually ultrasound through the layers of the stomach and look at that pancreas up close and personal and figure out what's going on. So we have criteria for chronic pancreatitis. It looks all shriveled up, scarred up. The ducts are all strictured and narrowed. We can see cyst and we can see cancer. So we want to get up close and personal in case someone has chronic pancreatitis, their pain gets worse. You want to figure out what's going on. It could be cancer. So I'll give you guys a couple of scenarios to understand whenever you have symptoms that you're concerned about. So a long-time diabetic patient, right? Someone who has type 1 diabetes or type 2 diabetes, who's been on insulin forever, who all of a sudden now presents with a bout of pancreatitis, red flag to the doctor. Because it means the organ is not working. Why? There could be a mass or a tumor in there. So you want to make sure that that organ is definitely checked. And in my practice, I mean, we always talk about digging deeper, but I think a lot of the experience I have is from experience with patients, something I missed, something I researched, something I learned from a patient, right? And I remember having a patient, this was just maybe 2 years ago, who kept coming to me with chronic epigastric pain. And guys, I did every test under the sun. I did CT scan, I did CT scan, ultrasound, EGD, colonoscopy, pill cam, test upon test. And his pain was kind of like just a nudging discomfort. It wasn't severe. And I said, sir, he goes, I'm going to forget about it, Dr. V. Maybe it's just bloating. And I said, well, I don't think so. Let's check in with each other again in 6 weeks. And we had a consult in 6 weeks. And I said, well, what happened to the discomfort? He goes, it's still there. And I said, we did a CT scan, but let's dig deeper. We did an MRI this time. And this time on the MRI, we found a 1.5 to 2 centimeter pancreatic mass. It was a pancreatic cancer. And I called MD Anderson right away, got an appointment. They have this whole system where the provider can get you an appointment like this. It's fantastic. Within 24 to 48 hours. And it was early enough for us to get the lesion out. They did surgery. Now, this is the thing with pancreatic cancer. If you have a hunch, you got to dig for it because it's extremely difficult to diagnose. By the time a patient presents with signs of pancreatic cancer, weight loss, bleeding, jaundice, yellowing of the eyes because the ducts are now obstructed, it's a stage 3 or stage 4. It's already advanced. So when you get these subtle symptoms of nudging and you can't find anything, you've done every test, keep digging deeper. Because in that scenario, you may actually save someone's life, right? And so patients have to be their best advocates. I was so glad he came back for follow-up. Like if someone would have said, it's just bloating, she's going to charge me a copay and what? He came back for follow-up. And every 2 months, he sends me a quick message through the portal and says, hey, Dr. V, this is what's going on. I went through my chemo. I'm doing great. I had the surgery. I'm doing great. So only the patient can be their best advocate, all right? That's absolutely very, very important. I want to answer some questions, guys, so we can finish this pretty quickly. There's a question about oral BCP. That is a peptide that is actually known to heal gastrointestinal structures. I do use BCP 157 peptide in my patients with Crohn's disease. I will use it with stomach ulcers. I will use it in a healing process after surgery. So that's a great question to ask. I wanted to share some important tips before I get off tonight because my family were like, you better finish this, get over it, and come chill with us. So I just want to finish some very, very important tips. A few things that I learned, right? I want to share something that's different that you guys may not know about. So there are opportunities, even after you've had, like if you have type 1 diabetes, there are opportunities to get pancreatic cell transplant, right? So islet cell transplant to restore the exocrine and endocrine function of the pancreas. This is happening in major institutions like Cincinnati Hospital. Hopkins was doing it. So just, always think outside the box, What we do in community may not be what is out there. And I love it when patients do research and come back to me and say, I discovered this, Dr. V. I can go here and get this done. Go all the way and do whatever we can. So pancreatic islet transplant was extremely important. There are artificial pancreas that can actually modulate the insulin, right? So you don't need to have that pump all the time. That is something I also discovered. Let me see if there's something else. I did all this research, guys. You know me, nerdy as someone. Oh, yes. Let me close by talking about some of the science in terms of functional medicine and how it relates to chronic pancreatitis. So when we want to treat chronic pancreatitis, we talked about malabsorption, and sometimes in acute pancreatitis too, digestive enzymes, we can give that as a supplement, as a support, because the pancreas is not making its own, and it makes a world of a difference. Digestive enzymes can actually reduce bloating, can reduce the pain, and improve digestion and absorption. So ask your doctor about digestive enzymes and high quality digestive enzymes. And we'll sometimes see in patients with Crohn's disease, there is an association with autoimmune pancreatitis and association with bacterial overgrowth. And we know that in those two scenarios, those patients just don't release enough pancreatic enzymes. It's kind of like the pancreas is a little bit sick. So we give digestive enzymes in those scenarios as well. But I did find that there are major studies out there for patients with chronic pain from chronic pancreatitis that show that forget the opiates, forget the Dilaudid, the morphine, and there's limitation there. Acupuncture, extremely good results. Meditation, yoga, extremely good results for chronic pain in chronic pancreatitis, and even post-surgery, pancreatic cancer, post-chemo pancreatic cancer. I was amazed to see how much research was actually out there. And so, yes, our doctors should be prescribing, those alternative regimens so we can heal. And shoot, insurance should be covering for all of that stuff too, right? They really should. So, few tips. We honor those that have gone. A lot of them had risk factors or bad lifestyle habits for developing chronic pancreatitis and pancreatic cancer. Don't smoke. Try not to drink any alcohol or significant amount of alcohol, and fix the root cause problem that is causing the pancreatitis. Guys, I hope you guys enjoy this. I know it's Saturday night, so for those who joined me, thank you. For those who are listening to this on the replay, enjoy it, ask questions. Tomorrow, I'm going to spend some time just kind of replying to a lot of the questions you all have had. Share this with someone who you know is suffering from either acute pancreatitis, chronic pancreatitis, or gallstone disease that doesn't want to get their gallbladder out, just to let them know the possible complications. If you have any questions, there's more to share about even pesticides and dyes and the risk of acute pancreatitis, but there's too much to share, okay? Once again, I always want to honor February, Black History Month, and tonight I'm going to put a plea out to African American men. You are the highest risk for pancreatic cancer, so make sure you are advocates for yourself and you discuss all your symptoms with your doctor, okay? Have a wonderful evening, guys. Tomorrow is our last night on Gut Over It. I have a special guest coming in to interview me. I cannot wait. We are going to be talking about SIBO and SIFO and IMO. And for those who don't know what that is small intestinal bacterial overgrowth, small intestinal fungal overgrowth, and intestinal methanogenic overgrowth. Have a wonderful Saturday. Give me some likes, share this with people, leave some comments, leave some reviews on Google about what you've seen on Gut Over It. Dr. Vivian Asamoah, gastroenterologist in Katy, Texas. One more night to go until we start our natural gut relief. Have a wonderful evening, guys. Bye.